अभी स्क्रीन शेयर कर रहे हैं क्या?
ऑन सर,
ऑन स्क्रीन।
वॉइस भी ऑन सर।
ठीक है, मैं लेता हूँ। Hello, good morning everyone. So shall we start the class? I think someone can put in the chat box if you're able to hear me. Okay, fine. So I hope you are aware about the topic. So today we'll be dealing with epistaxis and its management. I am Dr. Nitin. I'm senior resident in the Department of ENT. So if you have any queries at any time, you can put it up in the chat box, and I will try to clear all your queries in the end of the presentation. Is it fine? Okay, so I'll go ahead. I hope you are able to hear me very well and you're able to see the presentation. Can anyone put a yes? Yeah, thank you. So epistaxis, as you know, it's one of the very common emergency which we manage in our emergencies, and it's an emergency. So see, it's not a good time to tackle epistaxis, especially in the corona time, because in corona is actually mainly it's in the nasal cavity and nasopharynx, as you know, the majority of the viral load. So it's a risk for the health worker also when you deal with the epistaxis. Still, you have to manage it. Fine. So now there are many things which you have to know about epistaxis and its management. I'll be trying to see the practical aspects. Theoretical aspects you can see in your textbooks. Everything is given in your textbooks also. So we'll start with the presentation. So mainly I will try to deal with the epidemiology, the anatomy, the etiology, and the approach, and how to manage. So I'll be dealing more with the approach and how to manage a particular patient. Okay. So generally, you can see in 60% of the general population may come with the complaints of epistaxis to your emergency. So it's pretty common. And being a non-ENT practitioner, Also, you may have to deal with such patients. So majority of the time it's very mild, so they may not seek medical attention. So only 10% or fewer than that only seek the medical attention. And it has got seasonal variation. It differs depending upon the etiology of epistaxis. So this is the blood supply of the septum, what you can see here, and the lateral nasal wall. So you can see basically there are branches from external carotid artery system and internal carotid artery system. So the internal carotid artery system, you can see in the lateral nasal wall, there is the anterior ethmoid and posterior ethmoid artery. And you have the external carotid system, you have the greater palatine artery and the spinopalatine artery. Okay, you can see on the septal aspect, the blood supply is mainly by, again, it's a combination of external carotid artery system and internal carotid artery system. So now you can see something like a Kiesel-Black plexus, that's in the anterior most aspect of the septum. Okay, so I will come again to this particular thing, Kiesel-Black plexus, later. Fine. So this is the blood supply of the septum and the lateral nasal wall. In general, the nasal cavity. So based on anatomy, epistaxis can be anterior or it can be posterior. So as you know, when the patient presents to you and the patient is having bleeding from the nose, it's coming from the nose, so it's more likely to be an anterior nasal bleed. The patient is vomiting out blood, is spitting out blood mainly. So that indicates it's more likely to be a posterior epistaxis. It's not always posterior epistaxis. There could be other causes, but if the bleeding is from the nasal cavity or nasopharynx, the posterior aspect, then the patient will present with such a clinical scenario. So when you see anterior and posterior epistaxis, anterior epistaxis is more common, and the source is usually anterior to the piriform aperture. How will you tell whether it's anterior and it's posterior? So anterior means anterior to the piriform aperture, posterior means posterior to the piriform aperture. What do you mean by piriform aperture? So if you see the cranial vault, you see the bony opening of the nose. If you see the skull, you see the bony opening of the skull. So that is the piriform aperture. So whatever is anterior to that is anterior epistaxis. Whatever comes posterior to that comes from the posterior epistaxis. Generally, posterior epistaxis is seen in the elderly age group, and most common cause is hypertension. So the cause, if you see in anterior epistaxis, is mostly because of trauma. Trauma could be because of it could be self-inflicted nose pricking, or it can be an a road traffic accident, or a cell fall, or anything. And whereas the posterior epistaxis is mostly spontaneous. Now, if you see the amount of bleeding will be very mild in anterior epistaxis. There may be a few drops or a few ml of blood which will be coming in, which will stop spontaneously. Whereas in the posterior epistaxis, it's generally very moderate to severe, and it may require hospitalization. Initial time, they may not present with you because they may have something like blood in the sputum, or they'll be spitting out a little bit of blood, which may not be very much bothering for them, but they may go to a physician. Maybe the physician will consider this as a hemoptysis, and then they will be evaluating, and later they may refer to you to evaluate for the cause of any posterior nasal bleed. So this is in general anatomically how you can divide epistaxis. It can be anterior or it can be a posterior. There are so many causes if you see here. So it could be leading to some injury to the wall, to the wall of the vessel inside the nasal cavity, or it could be some mass lesion. So this is how grossly we can divide, and all these causes will come in either one of this. So you can see the local causes. It could be because of something like idiopathic or spontaneous, which is the most common. The vessel wall will rupture and it will start bleeding. Then it can be because of the trauma, because of the nose pricking, or it could be because of any foreign body, or could be a nasal fracture. Okay. So other thing is in any inflammatory condition, when you have a common cold, too much of congestion is there in your nasal cavity, you're not able to breathe and you're trying to force it out, and sometimes you will have a bit of bleeding along with that. Or it could be something like granulomatous virus, granulomatous disease, which may have much more systemic causes. systemic clinical manifestation, for example, like venous granulomatosis, sarcoidosis, tuberculosis, even higher altitude can also increase, leads to the bleeding. It could be iatrogenic also, or a post-operative also after surgery, because there will be a lot of trauma inside, because of which the patient can have intermittent bleeding, which will, after a particular period of time, which he heal and it will resolve. It could be a neoplasm or a mass. It could be n number of causes. Other than this also, there are many causes for nasal mass which can lead to epistaxis. Only some of them are highlighted here. Even in some medications like cocaine abuse can also lead to epistaxis. The structural deviation like a deviated nasal septum can also lead to bleeding. And we may have to correct the septum for the same reason. So which could be the indication for a septoplasty. So that also can lead to an epistaxis. And environmental irritants, different things are there which can lead to epistaxis. Now the systemic cause, as again I've told you, in posterior epistaxis, hypertension could be one of the reason, and there may be some other reasons like coagulopathies or something related to the blood, some issues with the blood problem. So, and something called a condition called hereditary hemorrhagic telangiectasia, where you have dilatation of the vessels and they may bleed at time of congestion or with a minor trauma. So, now one patient comes to you with bleeding. Now, how you have to approach this particular patient? So, you should have a holistic approach. So for having a holistic approach, you should see the patient. First, you have to see the vitals. You have to see the general condition of the patient. How is the patient? Whether he's in a state of collapsing or he's already collapsed. No, he's fine. He's coming while walking. So you have to assess the patient. First, you have to see his vitals. You have to see his airway. You have to see his breathing. You have to see his circulation, as in general, like in any emergency. And then you assess the patient, and then you have to address if anything among this has to be addressed. You have to address the patient. If the airway, there is a compromise in airway, you have to establish an airway. If there is a problem in the circulation, you may have to supplement blood products or something. And breathing, you have to assess. So now this is the initial thing. And next thing is, if the patient is fine, the next thing is you have to stop the blood loss. So that's what you have to aim at. So then along with this, you have to check for the BP, you have to check for you have to take a quick history from the attenders, like is there any history of recurrent bleeding in the past? Is there any history of coagulopathies? Is there any nasal obstruction or any other complaints patient had earlier? And if anything has been done before, like any procedure or any surgery in the past. So all this kind of short history, quick history you have to take. Now I will give some quick clinical scenarios. So what we usually encounter in our clinics. So for example, 3-year-old kid is coming to you, and the child is having intermittent mild bleeding. And you see the patient, he's walking, he's happy, he's playing also. And you examine the patient. So once the patient comes, you have to, his airway, breathing and circulation is not compromised, that you know. You can have a general assessment. You can see for a pallor if he's having too much blood loss. Doesn't look like he's pale. So now you assess his vitals, and vitals are fine. And then the next thing you should do is you have a look into his nose. So at present, he is not having any bleeding. So now when you look into his nose, so you can just pinch up his nose like this, and then you can see the anterior vestibule part and the anterior aspect of the nasal cavity. Now after this, you are not able to see anything, then you can use a speculum. The child may not allow to use a speculum, but still you can use it gently. So you can put a speculum and you try to see. Now you see, what you see is, I'm telling you the finding. What we are seeing here in this particular scenario is there is a wound, there is some kind of abrasion over the septum in the anterior aspect, and it's there you can see a small ooze, some kind of blood is coming out. So what could be the probable reason in this particular scenario? Can anyone answer? Okay, so as I told you earlier, in the septum, when we saw the blood supply of the septum, there was a plexus which was seen in the anteriormost aspect. No, someone has answered perforation. It's not perforation. Okay. This is a very common scenario which you see in Europe, in our OPD. So this is actually because the kid will be they'll habitually putting his finger inside his nose, and he may be scratching his nose. That would be one of the reasons. So you can examine his hand also and see for the nails. Okay. So what happens is this Kissen plexus area that is more prone for bleeding because there are a lot of blood vessels which are coming at that particular site. So any kind of minor trauma at that particular site can lead to bleeding. So this could be the most probable cause, and this is the most common cause which we encounter in our OPD. So this is one of the causes for anterior epistaxis, as I have already told you. Fine. So the cleisal back plexus, if any small trauma it happens, because of that reason, it can lead to bleeding. So I'll show you that slide again. So this is the cleisal back plexus which you can see. So there are supply. This is plexus of blood vessels coming from superior labial artery, and there is a branch from the greater palatine artery, and there is a branch coming from the anterior ethmoid. Even the septal branch of sphenopalatine artery also will be coming there in that particular site. So there is a plexus of blood vessels which lead to this particular problem. So this kind of patients, how will you tackle this kind of patient? He is stable, you are seeing him. Now you are seeing him and he's not having much bleeding, only occasional bleeding is there. So one of the issues could be because there might be because of the dryness, especially in Jodhpur. There must be small crusts which will be forming there, and because of that reason, the child will be putting his finger inside his nose and he will be trying to remove it. So what you have to do is you have to make it moist. So you have to put it in a humidifying environment. It's difficult here because it's a pretty dry environment here. So what we do is generally we advise something very simple, normal saline drops, which you can put frequently inside his nose and keep it moist. So it will provide an humidified environment, and such in this scenario, the bleeding will stop. In addition, you can give some topical vasoconstrictors. So you can give silometazolin, or silometazolin is one of this thing which can lead to vasoconstriction, and it can stop the bleeding. Okay. In some other medicines are also available. Medical management will be sufficient in this particular patient. Okay. So other thing is something called as Botroclot. Botroclot is a brand name. It is a hemocoagulase solution. So this particular solution you can put, that is actually made from snake venom. So this particular solution will help in coagulation. So it will stop bleeding. So it's a topical. You can just put few drops inside the nose. You can put it like two drops 4 times a day. And along with that, you can put a vasoconstrictor also. So with that, the bleeding will stop. So you just need a medical management in this particular scenario because there is not much bleeding. If the amount of bleeding is high, then the next role will come. There will be some kind of packing. Anywhere you have bleeding, you apply pressure over that particular area. So you have to apply pressure in the nose also. How can you apply pressure inside the nose? You can use different materials with which you can pack inside your nasal cavity. So this also will stop bleeding. So this is another way to tackle the bleeding. Now, how can you pack? There are different packing materials, as I told you. You can use long gauze pieces, thin gauze pieces. You can roll it up and then you can put it inside the nose. Or there are some packing materials, ready-made packing materials which has got a balloon, or which may be something like which will swell up if it get soaked. So something which we call as Mirosil. Mirosil is a material which is made of cellulose, carboxycellulose. So this particular material also can swell up and it will apply pressure and then it can stop bleeding. So these are packing. So when the bleeding is more, usually anterior epistaxis won't be that prominent, but some patients who may have a coagulopathy, in them it may not stop, or some other pathology, granulomatous disease also sometimes. So these kind of patients may require some amount of packing when the bleeding is too much, where your medical management is not going to work. There you need to pack. Okay. So I hope you are understanding. If you have any queries, you can put in the chat box. Okay. Now, you see the patient, it's already packed. One adult 25-year-old female is coming up. with your in your OPD, and she is already which is coming walking. So that means her ABC is fine. Now she has got a pack inside her nose. So the packing was done somewhere outside, 2 days back, and now she has been referred here for further evaluation. So now you take this patient in your OPD, okay, and you're assessing her. She is not pale, fine. So, but she has got good amount of bleeding for which someone had to put a pack inside her nose. So you need to address that particular bleeding site. So you need to assess where is the bleeding. So how can you assess the bleeding? You need to remove the pack, and then after that you have to see inside, okay, where the probable site of bleeding. So you remove the pack, and then you see inside nicely. You can use a speculum. If it's a speculum, if you are not able to see, the next step you can go for a endoscopy. So endoscopy, you can put a 0-degree endoscope. You can put the endoscope inside, and you can try to see inside the entire nasal cavity and try to find out where the bleeding is happening. So if you're seeing a particular point of bleeding and you think it's accessible from outside only, you don't have to do much. You can see a particular point, it's oozing from there. What you can do? We can cauterize that particular area. So I hope you know what you mean by cauterization. So cauterization means you are burning that particular area so that it will stop oozing from that area. So you burn that area, that will lead to somehow that will occlude this particular site, and then it will stop oozing. So cauterization can be done with some chemicals, or it can be done with electrocautery. If you have gone to OT, you would have seen something like we have an instrument in your hand, and then we'll burn some particular sites, and then we remove the tissue. I'm not sure whether you have gone to OT. I hope you would have seen an electrocautery. Otherwise, we will have some videos to show how we do electrocautery inside the nasal cavity. Okay, so you can burn with some chemicals like silver nitrate or copper sulfate, or you can use an electrocautery. With the help of electricity, you can burn that particular area and you can stop bleeding. Okay, so if you think it's accessible area and it's a point, it's just from one point it's oozing, then you can do this. Okay, now you think it's not possible, and you are trying to see there's diffuse bleeding from everywhere, then again you have to pack only. Okay, so now you see inside and it's coming from, you did an anterior nasal packing. Anterior nasal packing means in the anterior near you have completely packed everything. It will reach up to the posterior choana. It may not occlude in the nasopharynx sometimes. Then still after that also patient may be bleeding. What will you do in that scenario? In that scenario, we need to pack the posterior nasal cavity. So you have to do a posterior nasal packing. Okay. So this is with regards to packing, but packing is not a permanent solution, it's a temporary solution. So now you have to go ahead with the permanent solution. If with this step, if the bleeding is not stopping, you have to go ahead with the next permanent solution. So by the time when you pack the patient, you have got some time to evaluate the patient. You can do a CT, you can see if any mass lesion is there. You can check for the coagulopathy, you can assess for coagulopathy. If anything is there to be corrected, the platelet count is low, you have to correct that. You can correct with the blood products. If the PTINR is deranged, you have to, PTINR means prothrombin time. Okay, INR if it is deranged, then you have to supplement sometimes the frozen plasma. So as per the etiology, you have to correct that particular scenario, and then you have to remove the pack and see. If still the bleeding is not stopping, then you may have to go ahead with the surgical procedure. The surgical procedure can be addressing to the local cause, which can be ligation of the sphenopalatine artery or the particular vessel. Okay. Or if ligation is not possible, someone can address it through a percutaneous approach, that is embolization. Okay, so they put a catheter in the femoral artery and then they pass that catheter all the way up to the external carotid system, and they'll go and they'll put some embolization material. They'll block the blood vessel. That is the embolization. Okay, so that also can be done. other option is you can open up the neck, and then if you want to, that's the last resort, what you can do is ligate the external carotid artery. So this is the flow chart, how will you approach a particular patient. Okay. So the initial first aid measure which you can do when a patient comes to you, you can ask the patient to lean forward, you can sit and lean forward, and then occlude and pinch the nose and ask the patient to breathe through the mouth. You can sit for some time, and this itself can stop bleeding. This is known as the Trotter's method. Now, you can apply ice. Ice also can lead to vasoconstriction. So you can just apply over the nose along with this pinching the nose. So this is known as modified Trotter's method. This is also an effective method. This is the initial method which the patient can do himself at home, or when the patient comes to you, if he is still bleeding, you can ask the patient to do this manner. Till then, you can arrange your packing materials or the whatever procedure you are planning to do for this patient. Okay, so I have told you about this thing. You have to ask the patient about the history, about the duration, the site of bleeding, whether it's coming from one side, one nostril, or both the nostril, or it's coming from the oral cavity also. The onset, the timing, the severity, how many episodes the patient had. Then you can ask for any history of trauma. The patient had fallen down somewhere, or someone has hit him on nose or something like that. Then you can ask for any problem patient is having. Patient may have history of allergic rhinitis. He may have frequent sneezing, because of which also patient can have bleeding episodes. Sinusitis, hypertension. The BP is controlled or not, they are taking medications or not, any bleeding disorder in the past, any bleeding disorder in the family, then any liver disease, alcoholic liver disease. So then you can ask for any medication if the patient is already taking on any medication, like steroids. As we know, it can lead to atrophic rhinitis, and atrophic rhinitis also can manifest as bleeding. Aspirin, warfarin, clopidogrel, these drugs can derange the blood parameters, and which can lead to bleeding diathesis. In family history, you have to ask about the bleeding disorders, any addiction, smoking, cocaine, alcohol. All this history you will be asking from the patient. And then after your ABC, you will be assessing the physical, you will do the physical examination of the patient. You look for any signs of airway compromise, any hypovolemic shock, or anything, signs of coagulopathy, any ecchymosis, petechiae, tail injectasia. When sometimes dengue patients may manifest first as with fever also, with bleeding also, bleeding from nasal cavity. So all these things you have to assess. Then you examine the nose. I already told you what is Kiesel-Black plexus. So you have to inspect that particular area, have a close look for bleeding, any ulceration or any erosion. Also inspect the nasal vestibule septum turbinates for the source of bleeding. You can look for the posterior pharyngeal wall through the oral cavity. You ask the patient to open the mouth and see the posterior pharyngeal wall, so that you will know if any blood is trickling from above, from the nasal cavity or nasopharynx area. And if the bleeding site cannot be identified, in such cases, bleeding may be from a posterior source mostly. You have to keep a suspicion of that it's a posterior nasal bleeding, okay, which might have resolved already. You do the investigations. I told you have to assess for the coagulation factors. You have to assess for the same blood parameters, hemoglobin. And you can send one cross match, so that if there is a massive prolonged hemorrhage, for replacement of that, you need to supplement with blood products. So for that, you need to send a sample for cross match also. You can do a nasal endoscopy. I hope you would have seen in our OPD how we do a nasal endoscopy. You pass in an endoscope and you go inside all around the nasal cavity and try to visualize any pathology or a bleeding point in this scenario. The medical management I have already told you, different medical management. One thing I have already told you is the topical vasoconstrictors like salmeterol, Botroclot nasal drops is a hemocoagulous solution which actually help to coagulate that particular bleeding point and stop bleeding. Tranexamic acid injections also can be given, which can have a systemic effect, which can lead to platelet aggregation and all. Now, anterior bleeding, I've already told you about how to go out with the anterior bleeding. So what I told you, the cautery, cautery means you are burning that particular area. It can be a chemical or it can be electrical. So before you do anything, try to apply some anesthetic agent by topically. You can apply a few drops of lignocaine, a 2% or a 4%, or you can apply it in a patty, a cotton patty, and then you can put it inside the nose. So when you apply this cotton patty, you can actually use some vasoconstrictors also, like silometazolin or adrenaline, diluted adrenaline. You can put it inside the nasal cavity and you can keep it for 5 minutes. This will give an anesthetic effect to the local mucosa. In addition to that, it will decongest that particular area. So there will be more space to work. So this we can do. We can keep some cotton patties which is soaked in anesthetic agent like lignocaine and a vasoconstrictor agent like adrenaline or a silometazolin. And then once you see the bleeding site, you can use a chemical cautery, silver nitrate. It comes like white crystals, small crystals, which is available here in our OPD also. So you take a very small amount of crystal. We have to take it carefully because even if you take with a bare hand, it will burn your hand. So you make a solution with a few drops of NS, and then you take a soap stick, you dip in that particular solution, and then you apply over wherever it's bleeding. You apply over there for a few seconds, you keep, and then you see it will be burning all around, and then it stops the bleeding. So once you do this chemical cauterization, after that you need to maintain the you have to keep it moist. You have to make it it should not form further crusting. So for that you can either use some antibiotic ointment. Don't use the fingertip, you can use a cotton swab, and then you can apply some antibiotic ointment, mupirocin or neomycin or something. And you can add your medical management, which I have already told you, along with this after this cauterization procedure. Okay. Even posterior nasal bleeding also you can manage with a cautery, but it's difficult to do a chemical cautery. But with the electrical cautery, you can be much more. You can approach the bleeding site much more accurately. So the advantage is hemostasis. You can achieve more than 90% of cases. Patient need not to be hospitalized. This case is a OPD procedure, so the patient can undergo the procedure in the OPD itself, and then they can go home. So one important thing which you should notice, you should not cauterize both the side of the septum. What happens is burns that particular mucosa. So when it burns that particular side of mucosa, that particular side bleeding, the blood supply is compromised. If you do simultaneously on the both side of the same at the same side of septum, it can lead to septal perforation because there won't be any blood supply and the cartilage will be devoid of any blood. It usually gets its blood supply from the perichondrium. So the perichondrium doesn't have any blood supply. Ultimately, it will go to a septal perforation, which itself can lead to bleeding problems later. So the disadvantages, you need surgical expertise. If you accidentally touch some other site, that itself can lead to bleeding. So you have to be very precise when you do it. You should have previous experience when you do this particular procedure. The silver nitrate crystals are actually costly, and the availability is also some issue because it's available in this chemical shops. It's not available in any medical stores. So you need to procure from there. Complications, one I told you, bilaterally if you do septal perforation can happen. It's not very common. Complications are not very common with this particular method. It can lead to palatal numbness. Lacrimal duct injury can happen because of that. Patient may have complaint comes back with lacrimation, increased lacrimation, and optic nerve damage. It's very rare. It's like too much posterior. If you go, optic nerve may be there inside the sphenoid sinus, so that can lead to optic nerve damage. But these complications are very much rare. So this is one video which shows you about chemical and electrical cauterization. I hope the video will be clear. So the patient is sitting right in front of you, and doctor is examining her with the headlight and putting a nasospeculum inside her nose and visualizing her septum and lateral nasal wall. So, see, there is a point which you can see in the, it's in the septum and the anterior aspect. So he is using a soft stick, which is with this thing, chemical cautery, which is applied there. Sorry, this is a decongestion which they are doing, yeah. With the cotton patty. And this is the soft stick you can see he is applying over that particular area, and you can see it's already burning that particular area. So after burning, the bleeding usually stops. Okay, and this is the electric cautery which we are using. It's a bipolar cautery. It has got two poles. So whatever the area is in there in between that particular area, it's get burned. Okay. See, now it's oozing much more. So you cauterize that particular area. Now it has stopped. So this is the electrocautery. Fine. So now this is the packing which I was telling you. There are different ways which we can pack. There are different packing materials which we can use. The one in the picture you can see is the cotton gauze which is being rolled up. So the before packing, what we do is we actually apply something over the ribbon gauze. Either we put an antibiotic ointment or you can put something like a jelly, so that it will go inside the nasal cavity smooth without injuring the adjacent area. So packing you can do by layer. You push one part, the inferior most part, what you're seeing here. Then after that, above part and above part and above part, and slowly you can put multiple layers of packing inside the nasal cavity. So packing you may have to do only in one nostril. If it is a single nose bleed, if it is both nostrils bleeding, then you can attempt both the nostril packing. But sometimes if the bleeding is only from one nostril, and if you pack only the one nostril, still the bleeding may not stop. That means the pressure is not adequate. So you need to give a counter pressure. The counter pressure you can give if you pack only the other nostril also. So if you pack the other nostril along with this, the nostril which is having bleeding, that will apply more pressure and then it can stop bleeding. So the advantage is it's easy to do, and it's one of the techniques where you can buy time to tackle the actual etiology, the pathology where it is there. Okay. And it has got multiple disadvantages because it may lead to further injury, further mucosal injury. It can lead to septal perforation. It can lead to LR necrosis. It can lead to infection, and it can lead to cardiopulmonary complications, vasovagal attacks, and patient will require hospitalization after nasal packing. So these are the different materials which you can see, which we use for nasal packing. So you have the Mirosil, which is carboxycellulose, and you can some other materials like Epistat. You have the Cultostat. There's a Simpson balloon, which you can see down. So there's a balloon kind of thing. There is something like a pack kind of thing. Mirosil is the most common one which we use. Cultostat is also something similar to that only. Okay, rapid rhino is something like Mirosil, which has got a balloon also along with that. Okay, so these are the different materials, the pictures you can see here. So this is a conventional packing, which I've already told you, which we put in layer by layer. Okay. So they are putting few drops of some local anesthetic agent so that the patient. Yeah, someone has asked me the question also, when we put any foreign body into the nose and sneezing occurs. So that you can apply some topical analgesic agent. So that can desensitize that particular area, and then you can use packing. Still the patient will be too much of discomfort. Anything you put inside your nose, patient will have some amount of discomfort. To reduce his anxiety, you can give some anxiolytic agents also prior to packing. But when your patient is already in so much of distress, patient is bleeding so much, if you have to intervene fast, then you may have to do it without any anesthetic agent. So for your question, the answer will be you can apply some topical anesthetic agent prior to packing. Okay, so this is how you pack in layer by layer. That's the Tilly sources which is using for packing. Fine, I'll go ahead. This is mucosal nasal packing.
It's actually what I use the most.
So you can see this is a single thing. If you put it inside the solution, it gets swollen up.
That will expand when exposed to humidity.
See how it is expanding. I hope it's clear there also. So this, as it expands, it will give tamponade effect. One more advantage is this material leads to less trauma. So because of that reason, this is much more preferred. It won't traumatize the adjacent mucosa. You will apply something like a lubricating agent, like a jelly in this scenario also, or an antibiotic ointment, and then you apply it inside.
We're gonna do the left one first, okay?
Okay.
All right, lay back for me.
So again, the idea is same.
More water in there.
This is, we can put water to make it swollen up, or you can put vasoconstrictor solution also, so that that will also give additional effect to stop the bleeding. So antibiotics, generally we should not give antibiotic as a prophylaxis. It depends upon the case to case. You see the patient is at high risk of infection, then we may give some antibiotic like diabetes, advanced stage, or any immunosuppression is there. Then we can give antibiotics, which should be addressing mainly staphylococcus. Okay. So we can give antibiotic. So we have already told about this. This is a thrombogenic. There are some other materials which we use. This we generally use intra-op during any surgery if bleeding is too much there. You can see something here, flow seal. This is a hemostatic matrix. So this actually has got some thrombin and this kind of material which you just put it over the bleeding vessel, and it will have a local effect on that particular area and stop the bleeding. Gel foam, it's a gelatin that also has got some kind of hemostatic effect. You can apply gel foam. Even gel foam, powdered gel foam is what we use in embolization also. Surgicel is again a cellulose-based material which can be used to stop bleeding. So this also can be put upon the bleeding point. You can, along with the packing, it will be much more effective, so that it will aid in stopping the bleed. Now, if unilateral, as I already told, if unilateral nasal bleed, you pack, still the bleeding is not stopping, then you may have to pack the opposite side. Now, even after packing the opposite side, still the bleeding doesn't stop. That means there is something posterior to this particular pack. So you need to do a posterior packing. Now we'll go with ahead with the different techniques how we can stop the posterior packing. Before that, the simple techniques I told you to sleep in a humidified environment. I told you one more thing, that you can just put normal saline drops in the nasal cavity so that it will keep the area moist. It will convert the environment to a humidified environment. Topical antibacterial agent can be applied over this thing to avoid the crusting and all. Even the petroleum jelly also should be good enough. And when you, any kind of nasal medications, especially the nasal spray, the steroid spray, when you apply, you have to tell the patient to direct it away from the nasal spectrum. So it should be directing into the sinuses, so that this also can decrease the risk of epistaxis. Now, posterior bleeding, again I told you, you have to pack the posterior aspect. So how you can pack the posterior aspect? You can use conventional bolsters. You can make a bolster, put it inside a mouth. Okay, bolster, you big bolster you can make with cotton gauze and all, and then you can put 2 ties. You can take it out through the nose. You put the pack inside your mouth with the ties, and this ties will be taken through the nose out, and then you pull the two threads, so that this bolster will go inside and occlude the nasopharynx. That is the Belloc method. You can see how it is done in that particular diagram. It is shown very well. You have a bolster with some threads attached to it. You pass some kind of catheter through your nose and then take it out through your mouth. Then tie this threads to that particular this thing, and then you remove the catheter. So when you remove the catheter, the threads will be coming out through the nose, and along with that, the pack will be coming to the posterior aspect, and it will go and occlude the nasopharynx area. So that's how it packs the posterior nasopharynx. Other than that, we have some ready-made balloons, like you can see the Brighton nasal balloon, you can see have the Bivona triple lumen catheter, or you can even use the Foley's catheter also. So Foley's catheter, I hope you know, it is used for urinary catheterization. So you can just pass this catheter through your nose, go behind, inflate the balloon with 10 to 20 ml. Usually we use distilled water, not even saline, because something liquid will give more pressure, and saline, it has the characteristic of getting precipitation, and because of the precipitation, when you want to deflate it after 2 days, if the precipitation occludes that particular pathway, you may not be able to occlude it. So that's the problem. Okay, so usually use the distilled water to inflate on these balloons, and then along with this balloon, you need to pack it also anterior also to give it more pressure. So the packing materials, this is a short video.
Here are some tools and products that you need to know how to use for epistaxis.
You can see the different instruments which have been used to control.
To help clamp bilateral pressure on the soft part of the nose. You need a nasal speculum. Remember, it opens superior, inferior, not laterally. Don't injure the septum further. And you may want to have some bayonet forceps horizontally, parallel with the patient's palate. Next is the rapid rhino. Remove that outer covering, and you're going to soak this in sterile water for 30 seconds. That activates that spongy material, which helps activate platelets. Again, insert it horizontally.
So this is a rapid rhino. I told you it's kind of Merosel with a balloon inside.
And this gets taken. All right, let's see the big guns, the posterior packs. This one is the EpiStat. It's an open catheter to allow for airflow, and you're going to inflate that posterior balloon with 10 cc and full gentle traction.
So this is something for the posterior nasal packing to occlude the posterior aspect. They are inflating with the
30 cc, and you may not need that much.
See, this has got two balloons. One is for the posterior and one to address the anterior aspect.
Gentle traction, same technique here, and then you can inflate the anterior balloon also with 10 cc. Now these are just a few examples. There are a lot of products out there. We have no affiliation with any of them. We just want you waiting to stop.
So this is the catheter nasal packing, one video which we have. So this is a Foley's catheter, as you can see. You're passing the Foley's catheter through the nose. You are depressing the tongue and trying to see the other end of the Foley's catheter. So you can see the other end of the Foley's catheter there. Now you have to inflate. You have to inflate the balloon with fluid. The 10 ml fluid you put. Yeah, generally you can put 10 to 20 ml. Once you inflate it, before fixing this, you have to do a anterior nasal packing also. So that will also give a pressure from anterior aspect. And then you have to clamp this particular thing. And with the clamp you can see here. And make sure that that clamp doesn't apply pressure over the ala. So to prevent the chances of ala necrosis. And then you can fix it. Serially, you can deflate this particular catheter. Then you can assess also within 1 or 2 days, and then you can remove this particular catheter. Okay. So hospitalization, I have already told you. It's after packing, you have to hospitalize the patient. Then you have to observe the patient. Antibiotics may have to be given. chance of infection is there, sinusitis is there. So you need to assess these particular patients. Complications I have already have addressed. They can be additions, we can lead to intranasal addition because it will traumatize the adjacent mucosa, and the mucosa can join each other, the lateral and the septum. So that can lead to synocape, it can lead to aspiration, angina, myocardial infarction. The rarer complications which can happen with nasal packing. Surgical treatment, we just go through it. As I already told you, you have to address the blood vessel, bleeding blood vessel. So if it is a posterior epistaxis, most commonly it will be from the spinopalatal artery. Spinopalatal artery is a branch of internal maxillary artery, which is in turn a branch of external carotid artery. So internal maxillary artery, it's come in the pterygopalatine fossa. The pterygopalatine fossa, it's a fossa which is, it is behind the maxilla. So you have to address that, you have to go to that particular area. When you go for the surgical treatment, first you go for a spinopalatal artery ligation. The spinopalatal artery is a more terminal artery. You try to identify that particular artery, you can catch hold of it. Either you can put a clip or you can apply diathermy over the diathermy is cautery again it burns. So usually it's seen at the level of ethmoid crust. So if that is failing, then you can go out with the next step, that is the maxillary artery ligation, which is for the proximal branch. So proximal to the spinopalatal artery, then you can find out artery and then you can clamp that particular artery. So that is approach where Carvel-Luck approach. Carvel-Luck approach is sublabial approach. Okay, sublabial means inside your lip, the upper gingival-buccal sulcus anteriorly, close to the canine fossa. Okay, so there you can put an incision, open the antrum, and then you can go inside. So that open the antrum means antrum is maxilla wall, anterior wall. Anterior wall, antrum is the maxillary sinus. So you just open it, go inside and see, and then you can see the bleeding site, and then you can upload. Right. If this doesn't work, then you can go out with the external carotid artery ligation. You can put an incision over the neck, find out external carotid artery, and then you can ligate. That's the final result. Embolization is another option which you can do, that you have to occlude that particular blood vessel with some embolization agents, which can be, as I already told you, gel foam, or it can be some acrylic glue kind of materials are there which you can use for embolization. So, but this embolization has got its own complication. If it goes to the internal carotid system, it can lead to CVA, hemiplegia, ophthalmoplegia, even vision loss, cranial nerve palsies. All these issues can happen. So this is the general and flow chart how we go ahead with the management of epistaxis. We have already gone through all of this. If you guys have any doubt, you can ask me. We have approximately 3 minutes left. You can put in the chat box if you have any doubts. I think we have covered most of the things. There are few MCQs also in this particular topic, which I have covered. Would you please share the PPT? This PPT is very big. So we will try to share you. If you can put one of your mail ID, we will share to that particular mail ID. See, someone has asked how long the nasal packs has to be